And unfortunately, we have unsuccessfully tried to complete this task in terms of completing it. The reality is that Howard's Hospital, one of the things that I think a lot of my alum don't realize, but they tend to be pretty passionate about, is us owning our own hospital. But sometimes I think we have to go back and look at our history. Freedmen's Hospital was built in 1862 to serve, freed slaves moving from the South. It was then gifted to Howard by Congress in 1962 via Transfer Act. So really, for 100 of its first 100 and almost 55 years, it wasn't owned by Howard. We've owned it less time than it's been there. That's the first thing. I think sometimes because the new hospital was built, people also probably get that issue confused. But again, it was built by the federal government with the deal being that we would operate it as a hospital for a minimum of 20 years. And so we've done both of those things. The academic medical centers in the city all got into relationships appropriately so for their hospitals back around 2000. And we unfortunately had a deal that we were working on for National Capital Medical Center that didn't go in our favor. And I'm not going to retread that. I think my predecessors all acted in earnest. We just didn't get it done. So the point now is that we have a hospital that was built in the 70s. As you can imagine, there's structural things about it that don't make for the practice of modern medicine. We still have a hospital where rooms are connected by one bathroom. Those are things that just don't exist in a modern day hospital. And those are things that if you try to go and renovate, it would cost about $250 million. So rather than do that, we felt that we should bring about a new facility. And then the last part of it is, given where technology is, to retrofit a hospital of that age in a modern fashion, especially with young students that you're trying to train, is also an unrealistic, attempt, I think, to bring about the high level of medical education, healthcare education that we want to provide as well. So that's, it certainly wasn't my idea. It's one of those problems you inherit in these positions, and you could either belabor the point about what didn't happen before you, or you could just take it on and try to put your own spin in it. That isn't always popular because everybody else always has the answers since they've dealt with the problem before. And sometimes I think you've got to just make sure that you're doing the right things and getting the right types of information in and keep moving forward. And people are always going to question why or how, but I think we're doing the right thing and we're on the right track.
Great, thank you. You mentioned talking about the logistical challenges of the hospital and some of the, the expenses as to just making some changes and updates. So it makes a lot of sense in terms of building a new hospital from that angle. But how do you see the hospital changing healthcare in the district? I mean, we talked about the physical plant. What about the larger issue of healthcare in the district?
Yeah, that's a great question. So I'll just give you some data. Let's deal with the COVID-19 pandemic. 42% of the patients who were hospitalized at Howard during the pandemic have been from Ward 7 and 8. 70% of the patients who've been hospitalized have been African American. In a city with 46% African Americans and with an incidence of the COVID-19 infection around 47%. But a death rate that is disproportionately affecting African Americans almost all the way between 70 and 80%. We certainly represent an institution where those patients are coming to get care. And so our ability to provide care there is important. But I think what's more important is that this bill is not just about a hospital. It also involves 5 centers of excellence in areas that the city is really struggling. One is sickle cell. I myself suffer from sickle cell. I'm homozygous SS. And so I came to Howard. That's one of the compelling reasons for me to come. My mom was a nurse, and she felt that if I was going to seek a tertiary education outside of Trinidad and Tobago, that I should go somewhere where at least I could be taken care of. And the healthcare that I got as a result of that sickle cell center has been absolutely fantastic. I have not met another surgeon who's homozygous for sickle cell. I'm sure one exists somewhere. But the point is I'm a product of Howard and its healthcare system. And so our ability to expand that is important. The maternal mortality rate in DC is unbelievably atrocious. I would say we even have a moral obligation, I think, as a society to really beg the question about what's going on with that. And again, I think investing in a center of excellence that looks at that is important. Violence prevention, gunshot wounds and murders, homicide is up. Getting on the front side of trauma is important. I happen to be a type 1 diabetic as well. Diabetes has a high incidence in the district and has led to a high incidence of end-stage renal disease as well. So again, having focus in these areas, mental health, substance abuse, it's all the right things that disproportionately are affecting the African-American citizens in the district. And as a result, resulting in significant differences in life expectancy for African Americans, especially African American males versus their white counterparts. So I think it's a shrewd investment, and it's not just an investment in a hospital. So I think it will do a lot for healthcare, in particular in the district.
Great, thank you. That's all great information to know. I would be remiss if I didn't note that we have I lost count as they were entering, a number of past presidents of MSDC and MedChi DC, and a number of Howard alums on this in this meeting. But I think really the focus of the attendance is in the physician community. So we have a lot of physicians, probably all physicians at this meeting right now. Can you talk a little bit physician to physician about some of the features of the new hospital that they should know about?
Yeah, so what we're trying to do is, there are a couple of things, and we are still in the planning stages. There are three things that we're trying to accomplish. One is to make sure that we have a modern, high-tech facility that incorporates technology at a very high level, things like artificial intelligence, et cetera. So in a modern hospital, everything from the technology that's embedded in the beds, in the restrooms, et cetera, again, it's something that we're working on. We also are courting a tech company as well to use the hospital as an opportunity to kind of put some things in that they've been focused on. So I have a couple of meetings coming up to look at that. So we're looking at things like being able to take vitals without actually having somebody go into the room and do that. Looking at transportation modalities that don't involve a whole lot of lifting of the patients and things of that nature. Collecting urine samples when people simply use the restroom. So several things we're going to look at in terms of trying to make it as high tech and really leverage today's modern technology. The second thing that we're trying to do is to make sure that we have an efficient use of space where the patient is the center of our affection, as my mentor, Dr. LaFall, always used to say. So we want to make sure that all the healthcare professionals, social work, nursing and allied health, pharmacists, et cetera, really can interact with one another and the patient as appropriate as possible, and not build a hospital really around the physician, which sometimes has happened in the past. And then the last thing, which is just as critical, is to try to preserve the history. Part of this academic medical center complex will return the medical school to the old Freedman's Hospital site, and we also are going to court an architect who will capture the history of Howard medicine throughout that entire plaza, because I think that's a history that must be told. There's several giants in medicine that we've lost, especially in the past 12 months from Howard, and I think one of the things that we must do to this generation coming through is to make sure that they are aware of who these people are. The incoming class who will start this month will not have met these people. They will hear of them, and if we don't have a concerted effort to tell them that history, tell them the history of Freedman's Hospital, tell them the history of the nursing program out of Freedman's, tell them the history of even Freedman's babies. If you look at the people who were born there in DC, at that hospital and what they've gone on to do. It's an incredible story to be told, and those are books, probably even movies that documentaries that need to be done. So we intend to have this project be an opportunity for us to capture and tell our history as well.
And I have to say, as someone who is a native of Washingtonian, that is a very exciting thing to hear, because there is so much history that that's going to be a great project. So you touched on medical education a little bit. Can you talk about, in the lens of the new hospital, how that's going to work to improve medical education and allied health education in the district?
Yeah, it's a good question. Right here in the district, we have a gem of an institution that I think the district often doesn't leverage. I consider this a college town. As a matter of fact, if you look at data, if you just want to take the data and you look at Boston and DC, DC probably has more students per capita of the rest of the population than any other city in America. And you've got institutions that really focus on healthcare education and medical education in particular. So I think there's a great opportunity for us to expand that. Our relationship with Adventist is going to allow us access to 3 other hospitals, and that will give us an opportunity to expand the clinical exposure for our students and trainees. We have residency programs that we no longer have in areas that I think we have a crisis in terms of lack of diversity. Anesthesia, if you look at the number of African Americans who are training in that specialty, radiology, radiation oncology, to name 3 that we had and we no longer have. And I think this is an opportunity for us to bring those training programs back because of the clinical exposure that we will get. On the allied health front, and I would also mention dentistry. We get a lot of information about medicine because the AAMC does a very good job of collecting that data and publishing it. The American Dental Education Association, I've been interacting with them because I feel that the data is probably similar. Well, it actually is worse. The number of African Americans who are pursuing dentistry has fallen off the cliff. And again, building a facility and especially a new dental school, as well as a new hospital where you can have some practice sites for dentistry, I think is critical as well. When we look at our pediatric dentistry program as an example, it's critical. Nursing and allied health, definitely, and we have the only pharmacy school and the only dental schools in the district. So what Howard provides in terms of healthcare education, and we know from data as well that our graduates tend to stay in this area and practice. And so I think it's a more holistic investment that really gets focused on medicine often, but it's a lot more holistic than that.
Great, thank you. We have a few questions about the hospital, but I'm going to put those on pause for a minute because there's a couple of other issues that we want to talk about tonight that I want to get to and give you time to share your thoughts on. And I think the next thing we're going to move to is kind of probably the big political topic of the moment. The racial justice movement that we've seen spring up, especially in the district, but nationwide. Can you share your views and thoughts on this movement that we're seeing here locally in DC?
Yeah, and unfortunately, I probably can't be too politically correct about this. Howard University's DNA is social justice. So this is not a new movement for us. This is not a reaction to another, publicized murder. George Floyd's life, like all our lives, was priceless, and to be taken away so graphically and so callously is unacceptable. But the reality is that Howard University exists for that very reason, to prevent that, to call that out, to expose that, to offer solutions for that, and that's what we've been consistently doing. I think it's encouraging that it's getting a lot of other attention, but like every other incident that has occurred before, when everybody takes their eyes off of this and people start coming out in the street and protesting, and as much as this feels more like a movement than a moment, Howard University is not going to go away. we're not going to change what we're doing. We're going to continue our efforts. Prior to this incident and the pandemic, actually last year, we began to focus on social entrepreneurship with an idea to, when we talk about innovation hubs, a lot of time we talk about it in terms of STEM disciplines. And the vision that we have is to put social entrepreneurship at the core of an innovation hub, wrap it in the social sciences and humanities, and power it and underpin it with technology, big data science, et cetera, and let young people and the rest of the society see that if you give people who want to go into political science and sociology and those types of majors the opportunity to solve the big problems of the day, criminal justice reform, income inequality, climate change. We have about 9 major problems that we think that they could be charged with solving. I think we can get the solutions that we need, and we could turn the protests into policy. And so Howard University is going to stay the course. We're happy for so many people to join the journey, but we also are not going to be daunted when those people leave the path that we're on. We're going to stay focused and committed to doing what we're doing. So whether it's health inequities or criminal justice, inequities, we're going to keep pushing forward and keep providing the solutions as we did with Brown versus the Board of Education, as we do every day when we take care of patients with healthcare disparities, et cetera.
You mentioned health. And so within medicine, obviously implicit bias is a major topic. You mentioned it at the beginning of the town hall, some things that MSDC is going to be doing or is doing. Can you talk a little bit about how the university and the medical school and the allied health schools are looking at or addressing implicit bias?
Yeah, great question. I give a talk entitled Unconscious Bias in Academic Medicine. As a matter of fact, I was slated to give that talk this spring at Penn and Yale. And I've probably given it now at least 24 universities and counting. And there are several things that I point out in that. The roots of unconscious bias are strong. And so what we try to do in our curriculum very early on is to make sure that students are aware of it and that they recognize that the patient has to continue to be the focus of our affection and the center of our attention, regardless of what station in life they come from. And as we continue to train people with that mindset and they continue to go on to practice and train others, we feel that continues to be a self-fulfilling prophecy. But it has several, I would say several facets to it. One of the things that I talk about in my talks, one of the first slides I show is Abraham Flexner. If you look at what Abraham Flexner's report spoke to at the turn of the prior century, it actually not just took implicit bias and promoted it. It really underpinned it in our medical education. In his report, he said a few things that today would be appalling. I think they were appalling back then, but culturally we were at a time when there wasn't probably much opportunity to push back. The first thing he said is that I found appalling was that Negroes should not practice surgery because of the chance of them passing on contagion, meaning that we were sources of infection and therefore we shouldn't be involved in surgery. He mentioned that women did not have an inclination for medicine and therefore they shouldn't do that. After his report, the 8 Black medical schools that existed went down to 2. Another interesting fact is right here in the district, his recommendation was that of the 3 medical schools in the district, George Washington, Georgetown, and Howard, only 1 should remain, and that was Howard, ironically. And so I think what he set in motion with medical education in particular really ingrained bias into what we do, and we have not recovered from that over time. Women are now starting to populate our medical schools more than men. There's some recovery there, but when you look at African Americans in terms of as a percentage of medical schools, it hasn't recovered. What I would also say about unconscious bias is that it exists in all of us. And that's the other thing. That's the first thing I think we all have to appreciate. It's not about them. And none of us should think that we don't do it. Because when I give that talk, I point out two other things. Abraham Flexner would go on to become the vice chair of Howard University's Board of Trustees from 1934 to 1936 and participated in the funding of Founders Library. So go figure, after writing such a report, that he would then participate in Howard University's project, as it were. And then the second thing I try to point out is that my penultimate slide, which used to be my last slide, until my wife saw my slides and pointed this out to me, was a picture of my kids who at the time of President Obama's first election were in my bedroom. My son was dressed as a surgeon in full surgical gear with a white lab coat on, and my daughter was dressed in a Howard sweatshirt. And so she gently pointed out to me that I had my daughter looking like a cheerleader while my son looked like a surgeon. So that's my penultimate slide. And my final slide is of both of them dressed as surgeons, and it's titled The Future of Academia. So the point is that it exists in all of us. And so we all have to stop ourselves every day and every opportunity we get to just simply ask ourselves, is there something that has happened in my past that is making me look at something slightly different, or engage or interact with a patient slightly different? And we have to be bold and forthcoming to speak to our students about that openly. Whether it's somebody who has sickle cell who shows up in the emergency room and we treat them as if they're drug seeking, or somebody who has addiction and we don't treat that as if it's a medical issue and treat them with the same compassion and care as we would if somebody had a large laceration on their arm.
Wonderful. I'm going to let you take a minute because we've gone through two major topics, and we've got a couple more to go. And I just want to remind the audience, if you have any questions about anything we're talking about or anything else, use the chat box, email me, hey@msdc.org. We've gotten a couple of them, and we're going to get to them in a bit here. But I thought next we'd pivot topics again to the university as a whole. MSDC works on issues with the consortium of universities here in the district. And every time I see Sally Cram and the staff over there, I want to give a virtual hug to them because running a university right now is not an easy thing to do. And let's segue into Howard's recent announcement for plan for the 2021 school year. Can you talk a little bit about how you envision the fall semester going, with the caveat that nothing is certain right now?
Yeah, I think that's a good intro. I happen to be chair of the consortium this year and next year. And so you're right, the staff, they're wonderful. I think the presidents have also been very good in terms of collaborating and trying to come up with solutions. I have a lot of trepidation about the fall semester. We did a lot as a country to flatten the curve, and to be quite honest, we've failed. So right now, as a country, I think we're running an experiment, a failed experiment. I think we have a little bit of a mad scientist type of control of it, unfortunately. And we also are putting in the wrong ingredients in it. Those three things don't bode well for a good outcome. What initially started as a direction of softening has now resulted in spikes. Most of those infections are probably occurring in younger people, and they actually are going to infect older people. And those older people, when they get infected, are going to die. And I just think that that's a very stark reality that we're faced with. So we do have a reopening plan. We are going to try to practice social distancing. We are going to require people wear masks. We are going to put out a statement of a pledge. And I'm going to trust my students. I met with my student leadership today. And I said to them, I'm not going to have you sign the pledge. I'm not going to have you sign a waiver. One of my first messages I put out when the pandemic hit was called the communal good. And I'm going to make it clear to them that we have a responsibility for each other. If Black Lives Matter, and that is not just a moment, but a movement, then older Black lives should matter. Black lives with diabetes should matter. Black lives with hypertension should matter. Black lives who are faculty members should matter. Howard University employs more African American faculty than any other single institution in this country. So if we really think Black Lives Matter, then we as a community are really going to have to respect that and treat each other with a lot more love. And that's going to be my message that goes out to the community tomorrow. That while Black Lives Matter, I hope that Howard's Black Lives Matter just as much, and that we do things to take care of our institution in the right way, that we trust our leadership, that we're willing to partner and hold each other accountable, and that we all are willing to make the sacrifices and not go out without mask, or not, forget to wash our hands and do all of the things that we need to do. It's going to be difficult. And I have to be honest with you, if the situation doesn't change by the end of July, we will have to stay online, because we have too much at risk, given the fact that we employ so many African-American faculty. I have a sacred obligation that's very different to most university presidents. I have the vulnerable population that I have to protect, and so the measures I have to take are going to be unusual. We are going to ask everybody to be tested before they come back. We're going to send them home kits to take those tests and send it to us. We are negotiating a deal right now that would bring free testing to all HBCUs. I hosted a meeting yesterday for all the HBCU presidents. Probably was historic because about 90 of them out of the 105 attended. And we're working on a regionalized solution, of which Howard would be a host site for that testing and contact tracing solution. Is this other thing that we have to add to it as well. But it's going to be very different from what we usually do. We have to de-densify the campus by at least 20 to 25% of students. And we're going to follow, the CDC guidelines. But if what is happening right now, the trend does not change dramatically by the end of July, I am going to make the tough call of leaving us online.
All right, you heard it here first, everyone. This is a tough decision, and that's the downside of having a university in a major city, I think, unfortunately, at the moment. I want to touch on medical education. I am not a physician, but my guess is that your education and the education of everyone on this webinar is going to be very different than what medical students are going to go through over the next year plus. Any thoughts on medical education?
Yeah, I think it's interesting. I still practice. I've operated, quite a few times in the past 4 to 6 weeks. In the middle of the pandemic, having to go to the hospital every day and see my patients, having to go to the operating room, having to have the patients be tested for COVID-19 before, doing the operation. And so the point being that we're going to adjust what we do, the preclinical years, as we used to refer to them. Now, we try to expose students to the clinical environment from day one. But some of the preclinical years are probably going to be delivered differently. There's no doubt about that. We're recognizing more and more that we don't necessarily need to have students all sitting in an auditorium with the great Aristotle professor at the front going over slides. As a matter of fact, students don't attend class. I still lecture to the sophomore students, and my class probably has a high attendance because I'm the president of the university, and that high attendance is still less than a third of the students who show up. They have lecture capture, they get the notes, elsewhere. I mean, they've already self-dictated what we should be doing, to be quite honest. Even as I think of us building a medical school, it's more for faculty and research than it's going to be for classroom activity at this point. So I think those things are going to change. Having said that, I was a medical student, in 1990 to 1994, and a general surgical trainee from 1994 to 1999. And when I think of the HIV epidemic and how we all reacted to that, I remember having to take AZT because I got stuck in the operating room. And I remember us, when we could not test somebody for HIV, checking their CD4 levels before we would take them to the operating room. And, all of those things that we do, it's a matter of transition. I have a daughter who'll be 14 this month and a son who just turned 16 in June. And the other day we were talking about that and about how much the world has changed. And I said to them, we're very adaptable beings at the end of the day. And while it will be different, it doesn't mean that it will be any worse. There was a time, I remind my kids, where you could walk up to the plane to drop a loved one off, right? Many of us probably don't remember that because we have gotten so used to what we do today. My kids can't fathom that there wasn't a security metal detector that you walked through when you went to catch a commercial flight. And that's because that's what they grew up knowing. So I think we're adaptable. It's going to change in terms of how we deliver the education. But the ultimate thing about medical education that is never going to change is that it's about humanity. And the patients are at the center of what we do. And regardless of what technology we use to do it, you can't replace that human interaction. It just isn't going to happen. So but what will happen is how we pass on information to others is going to change, and we have to adapt to that.
Wonderful, thank you. Yeah, the airplane example is probably the best one in terms of how quickly life has changed in the past few decades. So, so I would like to finish off my portion with a couple of speculation questions. I'll put the caveat out there that we're not going to hold you to any predictions that you get wrong, because I think we've all gotten a lot of predictions wrong over the past 6 months.
Yeah.
But I do want to give you a chance to kind of to gaze into the future a little bit.
Sure.
So talk to me about what you think Howard University looks like in 10 years.
Yeah. My goal is that in 10 years, Howard University would be led by a female president. I'm the 17th president. We've all been males. I'm the 7th Black president. We've had more white presidents than Black presidents, for those who don't know our history well. And I think it's time for us to have a female president, to be quite honest. So one of my goals as I wrap up my tenure in 2024 is to ensure that my successor is a woman. That's the first thing. 2/3 of my undergrad students are women. And I think that we have an obligation to reflect that social justice in our DNA fully and be true to our values around those things. The second thing is I intend for Howard to be a top-tier university, period. Historically Black college and university or not. That's a designation by law that exists, but the reality is Howard University, and when you look at it, the breadth of its assets, the 13 schools and colleges, having the only dental school and pharmacy school in the district, sending more African Americans to medical school from our undergrad than anybody else. If you look at Harvard's MBA program over the past 50 years, you look at the African Americans who attended there, the number one source of those African Americans who have done Harvard's MBA program was Harvard undergrad, as you would imagine, and number two was Howard. So as far as I'm concerned, in the next 10 years, we should be a top-tier university, competing for the best and the brightest students and faculty, and staying true to our mission and making sure that we uncover, unearth, and provide solutions for the ills of the world that disproportionately affect the African diaspora. And doing that, I think, at the very best level that we can, would put us among the greatest universities in America.
I think I can safely say pretty much everybody on this talk is pulling for that and wants to help with that goal, as well as the others. So thank you for that. All right, same question, but this time we're going to talk about the hospital and healthcare. 10 years into the future, what is the new hospital? What does healthcare in general look like in the district?
Yeah, I would like to see the hospital be just one asset of a comprehensive healthcare system that Howard becomes. Building hospitals today, I think, is just not what it used to be. And if we really are concerned about providing better care, we have to recognize that most of that takes place outside of the hospital. And so some of the things that we've started doing, we've had our nutrition students from the Nursing and Allied Health program shopping with our residents in Ward 7 and 8 for healthy, nutritious foods. Gone is the day when a patient should show up to their primary care physician and the physician poses a question of, tell me what you've had to eat over, since I last saw you. And that last visit was 6 months ago, and you tell them the last 3 healthy things you ate, and that's part of the interview. I mean, getting a download on what people may have shopped for may give us a better indication of really what they're eating, and looking at their health more longitudinally and recognizing that we have to do more outside of the hospital in a preventive manner would I think is appropriate. And so if Howard can lead in the area of population health and ensure that our ambulatory practice is robust and really doing things to assist wellness and not just intervening on illness, I think would make it a marquee institution.
Great, thank you. And then my final question for you, at least for me directly, same question, but District of Columbia. What does the District of Columbia look like in 10 years?
Yeah, this is a tough one. And since you're recording this, I'm going to have to make sure we embargo this until 9.5 years from now. When I moved here in 1988, I fell in love with this city because of the people, especially native Washingtonians, who unfortunately are becoming more and more rare to see and interact with. And that's unfortunate, I've got to be honest with you. I used to love running into somebody who told me that they were from DC and they were 3rd or 4th generation. They have a richness about the culture, personality-wise, etc. And I met a lot of those people through medicine, through doing rotations at DC General Hospital and Greater Southeast, and so I pray that they're able, in spite of all the gentrification, to stay rooted here in the district. A lot of them are descendants of Howard faculty and Howard alum from generations, and unfortunately they're getting pushed out of the city because of pricing and gentrification. And so I hope in 10 years we would recognize DC for its most valuable asset, and that it's citizens, especially those who have been multi-generational. I also hope that this will really be considered the college town that it is, and that the district government would begin to look at our universities for not just the economic engine that they are, but the intellectual property that they bring, and therefore really partner with them in a robust manner to ensure that they are strong and they continue to be great ambassadors for the city as well.
All right, thank you. Now we have a few minutes for a few questions. So again, I remind you, just put them into the chat box or email me. Again, we have a number of VIPs on this webinar, but I would be remiss if I didn't give a thank you and a shout out to Dr. Rosalind Epps, whose family name and herself, her accomplishments go without saying. So I want to thank Dr. Epps for joining us on this webinar, in addition to many other people. All right, first question from the audience comes from MedChi President Dr. Williams. And you touched on this, Dr. Frederick, a little bit, but talk about, the question is, what additional residency programs do you anticipate over the years at the hospital?
Yeah, I would assume that the question is what residency programs I anticipate bringing back to the hospital is what I'm going to interpret the question as. And I think the two that we first need to focus on are anesthesia. Actually, I should say 3. First 3 we need to focus on is, can we bring back anesthesia radiology and emergency medicine. We have a large number of students going into emergency medicine now than we've ever had before. And so if that's a popular choice of our students, it makes sense that we should be providing that opportunity for training at our own hospital. And given what we do in our emergency room, I think there's an opportunity there as well. So, it's something that I would love to see happen as well. The other thing that I would mention as well that I think from a residency training point of view is while things like radiation oncology are not large or even neurosurgery, the absolute dearth of African Americans getting into those fields probably mandates that we take a hard look at potentially bringing those to Howard. We haven't had a neurosurgery residency before, but I think it's something for us to be considering in the future.
Great. Next question came in via email. And you touched on this when you talked a little bit about the nutrition program, nutrition students at Howard. Howard University has a long history of serving residents east of the Anacostia River. Do you have any thoughts about Howard's footprint beyond the Anacostia River? And what other geographic locations will the new management, I'm assuming the new hospital management or yourself, be focused on?
Yeah, we have a practice site in Ward 7 now that was long overdue. And prior to the pandemic, it had a robust following. As a matter of fact, I myself went over there for my ophthalmology appointment and met a waiting room full of patients and got a chance to secret shop, sit among them and hear them talk about how happy they were that, they were subspecialists, being able to see them in their neighborhood. They didn't have to, take a couple of buses or jump on a train, etc. And so that, I think it's been gratifying to do that. There are a couple of things. I think when you look at the Southern Maryland corridor, I think there's an opportunity for us to have an engagement there. And obviously in areas like Mitchellville, there's also an opportunity for us to have an ambulatory presence there as well. So we are looking at sites right now where we can expand and certainly open up more ambulatory opportunities. Oral care, dental care is, I think, also woefully inadequate throughout the region in general. And so the other thing that we're looking at is putting a couple of dental practices in Southeast and also in Maryland. I think that we do have some alum who have private practices there, but I think it would be great for our students and faculty to get into those neighborhoods as well.
Great thoughts. And this next question follows up nicely with that. How about mobile clinics and telehealth? How will they factor into the business plan for the new hospital and the university as well?
Yeah, I think telehealth is important. That's something that we're certainly going to stand up. We've had an opportunity to do that during the pandemic, and we're going to continue to advance that as well. One of the things about telehealth that I think we're going to learn is we must have an extension of that to more healthcare at home as well. I sit on the board of Humana, and one of the major investments that we've made is in home healthcare. And I think it's extremely important. It's going to become even more important. During the pandemic, you had a significant rise in deaths at home year over year. When you compare to 2019, the same months of March and April in particular, you had a significant increase in deaths at home. And so, the data will come out eventually on what those deaths were from, but I would speculate that obviously some significant number would have been from coronavirus infections. But I would also not be surprised if some were from chronic illnesses that just weren't treated appropriately because people were not going to see their physicians. And that says something, right? A pandemic is one reason why, but on a day-to-day basis, there are people who are not coming to see us because they have other priorities, and we have to meet them where they are. And we have to provide care with a different thought process and through a different lens. And I think that that's instructive to us as well. So that home healthcare, I think, is another area that we have to strongly invest in, especially for vulnerable populations and in disease areas where, you think of diabetics who may not be as ambulatory and need podiatry, to have them come to a facility to get that done, as opposed to, having a unit that can go out and provide that care at home. There are probably lots of advantages to that.
And then follow-up question to the follow-up question. This comes from MSDC President Dr. Desiree Pineda. What type of outpatient programs will Howard University Hospital have to improve the health, compliance, and nutrition of its patients?
Yeah, as I said before, I think we have to partner more on an interprofessional basis with areas like nursing and allied health, et cetera, where they have robust programs in those areas and they're doing things, for instance, like shopping with residents and then trying to get that information to our primary care physicians about what they have, providing education as well to residents in their homes about eating, etc. But when you have food deserts and food insecurity, as you do in some parts of the city, again, you have to meet the residents where they are. And it's one thing to tell people that they need to eat fresh vegetables and do those types of things. It's another thing to shop with them and see what's available and try to be creative about building a meal program for them that's effective. And so those are some of the things I think we're going to have to continue to do in order to be effective. And I should say, and I say continue to do because we've already recognized that issue and started, doing things so that we can be at the front of that curve as well.
And I'm going to do a last call for questions. We have another question in the queue here, and it's a follow-up question about the new hospital. Just if you want to give any thoughts about how it would look operationally.
Yeah, I would say operationally, there's it's like I said, I think from a technology point of view, I think it will look different in terms of what we do. That's our intent, to build a very modern day hospital that uses all of those tools that we have. My hope is that we would do more wellness type things as well in the hospital, so that we can get people in the mindset that the hospitals are not only for illness intervention as they are right now. We talk about an acute care hospital, but really if we're going to build comprehensive facilities at this level and that cost that much, I really think they should be wellness centers as well. And so, the same place that people go to have a major operation could be the same place they go to work out and learn how to prepare a nutritious meal, and those types of things. And I think that really then benefits the community. And so operationally, I think what you will see is as much a focus on wellness as a focus on intervening in illness. And so our intent operationally is to make sure that is kind of what we put forward to the community.
Great. Well, recognizing that it's almost 7 o'clock, and I know, Dr. Frederick, you've certainly had a long week, and it's only Wednesday, and a busy week. I think we will wrap it up here. There's a comment in the chat that I want to end on, but before we get to that, I just want to say thank you for your time and coming and speaking with the Medical Society and its members and its guests. It seems like every day some really good news about Howard University is coming out in some way. Even the fact that Notre Dame men's basketball is coming to play at Howard, and I think it's January, even if it's something like that, there just seems to be great news coming out every day about the university. So thank you for everything that you're doing and, for coming out here today. I didn't know, did you have any final thoughts that you wanted to share with the group before I get to
Sure. I appreciate you for having me. My alum are robust supporters of the university. They definitely hold me accountable, and for that, I'm always appreciative. But I must say that their support has been invaluable, and especially in recent times. We think there's a lot more good news to come. So I would tell you, especially as you look at the Notre Dame news, I would ask you to stay attuned next week. I think some of the things that are occurring in our larger society are going to impact other things that they should have been impacting for a while. And there's going to be a sea change in a number of ways. So we can't do it without the support of the larger community. And so there's stalwarts in this community who are Howard alum, who have stood up Howard's values for a long time. And I have the sacred obligation to be the shepherd of that at this current time. And my intent is to guide that ship, to guide the ship appropriately, and to hand it over, like I said, to a woman who then takes it to some really large open seas.
Well, I will just, as I promised, end with a note from Rosalind Epps, who said, "Thank you, Dr. Frederick, for an excellent town hall. My father and I appreciate the content and quality of the interview." So there's no higher praise than that, at least from my perspective. So thank you again for coming out here today virtually. Thank you for everybody participating, and stay safe out there, everyone. Thank you.
All right. Thank you. Stay safe and stay healthy. Thanks.